Okay, my name is Ken Duncan. I work with the Bill and Melinda Gates Foundation, and I'd like to welcome you to this keynote session. We have 3 speakers this evening, and I'm sure you're all wondering what the big mystery is about the TBD in the title on the programme. I was surprised when I saw the programme that this was one session and we didn't have a single title. But I can let out the secret. We're actually going to talk about the 3 big diseases, HIV, malaria and tuberculosis. So one speaker on each topic. And I'll just, without further ado, go ahead and introduce the first speaker. What I will also say, though, is that we're going to take questions at the end. So there's 3 speakers will go sequentially, and then we'll take questions afterwards. So the first speaker this evening is Wendy Stevens. Wendy is Head of Molecular Medicine and Haematology at Wits University in South Africa. She's also Head of the National Priority Programmes at the National Health Laboratory Service in South Africa. And the title of her talk is Scaling Up of HIV/TB Proof of Concept, Point of Care Technologies.
Thank you very much, Ken, for the introduction and for the opportunity to talk to you today. I'm also at the stage of the evening where it's midnight, and I'm not sure if I'm talking about POC or proof of concept, but what I'm going to talk about are 2 parts to our project. The part that was funded by the Grand Challenges, looking at the feasibility of a multidisciplinary point-of-care project, and the second part is funded by, a part of it funded by the Bill and Melinda Gates Foundation, which really talks about how to scale up a project, and we're dealing with the gene expert as an example. Trends in technology, well, they've changed so dramatically, and I think all of you have spent the last few days doing exactly this, discussing it. In diagnostics, it's from one end of the spectrum to the other, from the simplified test, low volume, robust, all the way up to laboratories that are now doing similar things, just on a scale that's unprecedented. What I do want to point out is that the Gene Expert is one of the examples, I think, of a modular format which certainly works for a country like South Africa, where you have the flexible options of different volumes throughout your program, particularly if you have a tiered laboratory system. So if I have a look at the global perspective, and I talk just about Africa's unmet needs, but I think it's the unmet needs from the rest of the world too that are being addressed here. We're actually catalyzing an industry of diagnostics. And I think there's so much focus from the global community. It's been stated at IAS that universal access requires point of care. It's part of the global health strategy. Groups like funders here are focusing on it. The WHO has suggested point of care or simplified diagnostics are critical components. And then other partners, new partners like UnitAid, are catalyzing the market with market entry products and facilitating the uptake. And then at the same time, in all of these countries, there's a regulatory push to find out where to place them. And in South Africa, we're a little uncertain at the moment. We have huge plans for primary healthcare re-engineering, and point of care obviously has a place in this. But our burden of disease is really HIV and TB. And so there's the need for integration of both HIV and TB services, and hence the need for us to integrate them. And we'll talk about the project that was funded under Grand Challenges Canada. But all I want to say is that coming from the ASLM meeting, virtually the African Society of Laboratory Medicine, virtually the entire meeting was focused on issues around point of care. And really, when we talk about point-of-care assays, they straddle all disciplines, and all the stringent requirements that are being talked about to address the neglect of laboratories in regions such as Africa apply to point of care. And we think in our region that ASLM may be a mechanism for sharing some of this information. So why is South Africa maybe different for scaling up point of care than other countries? Well, it's the sheer volumes of our sample and the fact that we do have some infrastructure, which makes it much more difficult. If you have nothing, it's easy to implement. We have a lot of legacy systems, but we have a huge burden of disease. 5.7 million infected individuals. 70% of our TB suspects are infected with HIV, and we're looking at overall TB rates of close to 1,000 per 100,000. I mean, it's absolutely, completely out of control. It's increasingly smear negative. Areas we have shown some success is in our EID program. But the new mandate now in South Africa is that we need universal testing for HIV and TB, and it's part of the National Strategic Plan. And this is an enormous task ahead for us. At national levels, when we're looking at, sorry, it's quite difficult to see without having the screen here, but at national levels, I think we need to have point of care in our national strategic plans. We need to establish working groups that are functional, multidisciplinary working groups to decide what the national plan looks like and not just what we're going to do at individual sites. And I think there needs to be a needs assessment in many of these countries. I mean, what are the questions that you want to address or answer? Many of the developers here are looking at things in isolation, maybe just looking at a CD4 for treatment initiation of HIV. But we need to decide what it is we want before we know how to put a plan together. Do we want to address just HIV alone, or do we want to address treatment initiation as well? So there are niche markets and niche focus areas that you actually need to decide what the questions are before you can put a national plan together. So really whatever you do at a national level requires a full needs assessment. And our project focused on the feasibility, this was the project funded by Grand Challenges Canada, of looking at multiple point of care for the management and integration of both HIV and TB services. So we didn't think of them as individual silos of how we were going to do them. We needed to look at the feasibility of addressing the whole person, that person who had both HIV and TB at the same time. Part of the study also included a randomized controlled trial, and we'll be giving some preliminary data on that. That's a lot better, thank you. So we called it the Combined Clinical Point of Care Laboratory Platform. And we went around and found out what our clinicians wanted. And what did they want? Well, as per usual, they wanted everything. They wanted the full ARV and TB package. And so we had to go through a process of, and I've listed it here and it's been discussed in this morning's session, of a needs assessment, a selection of instruments, a full package that facilitated the development of the assay. And we chose several, and these are not the assays that we likely to just use for wide-scale implementation. They were really selected based on what was needed for the treatment guidelines and how we could facilitate an approach going forward. So we were looking at 5 different assays, and potentially as we move along and as we keep this project going, the numbers increase. Do we now not just have a CD4, a hemoglobin, a creatinine, a test for active TB, a test for viral load, but do we add things like CRAG, hepatitis B as examples? So the package really, we think, and I'm not going to go into a huge amount of detail, includes the needs assessment, includes the selection of the instrumentation, appropriate validation of those instruments in lab and field, and previously validated we discussed at this meeting several of the instruments that we validated previously. One of the new validations included one of the new viral load assays, the ICUM assay, which will probably now be tested in the field project as well. It's a really difficult process, the implementation. Don't underestimate how difficult implementation of any test is, and the linkage of that test to care. It requires a level of healthcare worker that is not really sophisticated. And so we had to develop site checklists. We had to develop really simplified training material, quick reference charts. We had to do site visits, and the diversity of sites were absolutely enormous, as was the skill of the individuals. We had to provide some verification and EQA material. Luckily for us, most of the EQA material we produce in-house was suitable for the point-of-care instruments, apart from the expert, which required a full development of a new EQA material, and in this case, developed by Leslie Scott, who works with me. We were able to develop a dry culture spot, which has really stood the test of time and been evaluated in over 800 modules now for verification of the instrumentation. And then an important aspect is the costing and modeling, and I'll talk a little bit about that for the expert. We did the field validation. I've got a lot on this slide. 2 urban sites we started with where we were sure we could probably guarantee success and develop a package. And both showed us that with the instrumentation we had selected, that we could do nurse operated point-of-care testing, and that the results were equivalent to the predicate laboratory methodology that was being done in parallel. And that involved 2 different sites and over close to 500 individuals. The second study was a field study that arose out of a need identified in the first, and that was really to look at feasibility and patient acceptance of finger prick for point of care. And we looked at about 300 patients. We randomized them to single finger prick for point of care, or multiple finger sticks for each point of care. And interestingly, we discovered that South Africans actually prefer finger sticks to blood draws, and that most of them, about 70%, would be willing to have up to 3 finger sticks before having a blood draw. So the next phase of the field validation was the development of the randomized control trial, and this was really to look at both impact and cost effectiveness of the implementation of this multidisciplinary point-of-care panel at clinic sites. We chose 3 clinics in fairly remote region in the Northwest Province, quite research naive. Staff were employed, nursing staff. They were trained and recruited in May of this year, and there was randomization by SMS and web to either point-of-care arm or to the standard of care. 302 patients have been recruited to date. Our statistical number, or aim, is to recruit 630 and obviously evaluate them at the 6-month and 12-month visit for impact. So far, if we have a look, there are, in the 2 arms of the project, they're predominantly female gender. There's very little difference in age, distance from the clinic. So demographically, they were very, very similar, the 2 groups, even in terms of employment status, in terms of mean CD4s. However, what our preliminary study results show that in the point of care arm, we actually were able to initiate a lot more people on treatment, and the days to initiation were really short. Now, I must put this in context, because if you were to look at the standard of care arm, you would say, well, we should chuck out all our laboratories and focus on standard of care. However, the median of 20 days it needs to be put into context. In most of the clinics, the clinic guidelines specifies the blood gets taken, but you only come back in 7 days for the results. Then you have to have 2 to 3 adherence visits, which takes another 7 days. So you're 14 days into the process before there's the potential for initiation. So 20 days was actually a really good result. The minister wants everybody to be initiated within 4 weeks. So this clinic was doing fairly well. But what it does say is we have to change our treatment guidelines dramatically to be able to put in point of care and make it effective. The need for connectivity, I think, has been discussed in numerous forums at this meeting and remains one of our most important priorities. And there's no real system yet that's perfect. There's some that deal with instrument and performance of instruments. There's some that deal with patient management. We need something in that orange area in the middle that deals and links. Clearer validation guidelines are definitely needed for point of care and consensus building. And I'm not going to go through the slide, but this is just for you to keep, that there are a number and an expanding pipeline of technologies, many of which you are aware of. However, I do need to say that many are early market entry or prototypes, and they're not much to use yet in prime time on a large scale. Just to say, the evaluation of one of the viral load assays it performed extremely well in our hands with a time taken of about 30 minutes. And we are going to put this into the 3 clinic sites that I've been talking about. So quality is extremely important, and there are a number of people who give guidelines about point of care. And in fact, in South Africa, we have now a national standard for point of care and a checklist for accreditation called ISO 22870. And this is, in fact, quite a stringent quality checklist for point of care, and is likely to make a difference, certainly in our setting. So who will perform point of care? Well, when we showed the slides this morning, actually if you add those 5 instruments, you add about 22 extra duties to the healthcare worker's job beyond treatment. So task shifting is going to be important. We think we're going to need dedicated staff. It might need to be a different health worker, a different cadre of health staff. But we do have problems in South Africa in that our staffing and their scope of work is quite highly regulated. It's been waived for rapid tests, but not yet for other testing. And if we have a look at the number of tests that are required per visit, we find that your average patient requires at least 3 tests. So don't underestimate the human resources that are required. We're talking about both diagnosis and monitoring. So the summary of the first phase was that nurses performed adequately using point of care versus laboratory. We think dedicated testing staff are needed at clinics. Urban implementation was easier than more remote sites. There was great variation in infrastructure, inconsistency in clinical practice at all levels, high staff turnover, and I mean, I could go on and on and on with the list of difficulties that face implementation, but I'm going to stop there. So really, when we look at a phased implementation or a national plan for point of care, we have a number of steps. And these steps have been developed over a period of time while implementing other programs, the viral load, the CD4, the infant diagnosis, more recently, the Gene Expert. And if you don't go through all the steps, and I'm not going to bore you with all of them, but if you don't do each part of the process, starting with the development of the plan, the training material, and ending up with monitoring the impact and the linkage to care, you're doomed to fail. So we think our study fits quite nicely with the Pandex concept, and I'm not looking for extra funding, but I'm saying the feasibility of putting 5 different instruments at a particular site is actually quite tricky. I'm now going to spend a bit of time showcasing the large scale-up that we've had to do for the Gene Expert, which we call near point of care, potentially point of care, and I'll talk a bit more about that. So besides the HIV landscape changing, we can't keep up with the TB landscape. And what we are talking about now is the expert, and I think it's probably just the first in class, and we are looking for competitors, despite how much we've actually placed of these analyzers. But there's movement in both directions. So we're talking about this modular format of varying size instruments with a cartridge that fits into a slot and very, very easy implementation. But what is this doing? Well, it's a completely disruptive technology, as point of care is. It interferes with your conventional microbiology, your other tests. Where do you place it? It interferes with the diagnostic guidelines for both HIV and TB. How do you address that? It interferes with, you need laboratory information systems, you need new quality management systems, training programs, actionable result reporting, data collection, financial modeling, and I can just go on forever telling you how disruptive and it's a word that David Persing actually used, and it's really been the story of the expert, totally disruptive in South Africa. What we have realized about the positive aspects is that you will find the weaknesses in your current TB programs. So the background to the program is that we used it as replacement for microscopy in existing microscopy centers. We have performed over 800,000 tests to date, and in high-burden districts know from a laboratory perspective that we have doubled our detection rates. And there are many studies emerging from South Africa showing the increase in laboratory detection, the reduced time to diagnosis and treatment initiation, but most importantly and most interestingly, a reduction in empiric treatment. So what was the success, and how did we get the funding to do this? Well, I think the success was that we followed that algorithm of developing a national plan. We had one national plan that donors could hang their hats on. We started with phase 1, and this, I must say, was driven politically by our minister. He gave a direct instruction to place the instrumentation in 9 high-burden districts in 9 provinces. We have completed the phase 2 of the high-burden districts, and we have come a long way in completing the extend study, which is the study looking at impact and cost-effectiveness that has been added. What I can tell you, too, is as a result of having a well-designed plan with us, we have now full financial commitment for the project. We based the numbers on previous volumes, and this was the laboratory situation and the number of microscopy centers prior to the rollout. We now have 100 testing centers in place. We have 143 analyzers. We have 20 clinic placements. And we have a range of instruments, and for Robin Wood, who thinks it's highly centralized, we are about to place a further 125 instruments, and when we have a look at them, 85 of them are going to be GX4s, 181 GX16s, and a number of infinities. And I quite liked the talk yesterday, modeling by Dowdy, and really what we're finding, he's completely correct. Beyond sensitivity and specificity, we've got to start doing our modeling. That the timing is important for transformative diagnostics. And the thing about the test, which resulted in us putting it out there, is that it is a better assay than what we had. So how did we go about doing the costing? Well, we estimated the implementation costs for the National Health Laboratory Network. We looked at how we had to inform national budgets so that we could get commitment from the Treasury. And we used a very crude, initially Excel-based population-level decision model, which focused on the entire process, including all the costs moving from TB suspect to TB case to TB treatment. We then built in the Extend study to verify the modeling and evaluate the cost effectiveness in the third phase of the implementation. What I can say is that if you ask different modelers, you will get different answers. And that's, although somehow our two modeling groups came up with fairly similar costs for the cost per suspect and the cost per case diagnosed, it's the inputs that varied, the suspects or some differences in costs. So the summary really was that we needed a whole lot of instruments, that it was going to cost us about 150 million rand for the implementation, that it was going to increase our TB incremental cost, but that if we decentralized completely, it was going to be about 50% more expensive. So the other estimates that were important were that we would increase the number of cases diagnosed, and the percentage and the timing thereof depended entirely on the rollout. And that with time, most of the diagnoses would be made up front with the expert. We also predicted the time to diagnosis would be much shorter, and that most of them would be done by at least visit 2, which is within 48 hours. But what really sealed the deal was that time to treatment was reduced. And this is a study done by Mark Nicol and really demonstrated how much shorter the time to treatment is, particularly in smear-negative individuals. So when we looked at the numbers that we could increase, so with laboratory, could we start with this type of picture based on the 2011 model, where we would eventually replace most with expert and we would increase the number of cases. What we, however, seeing is that we are reducing the number of empirically treated cases, and there have been several studies confirmed in places like Zimbabwe as well that although we're increasing laboratory detection dramatically, we are not increasing TB caseload hugely because we didn't realize how much empiric treatment was actually going on in South Africa. So when we redo the modeling, is it going to look like this? If we add the empiric treatment, the clinical, the extrapulmonary, and so the results from our formal impact study are going to be exceptionally important. So a model is just that. It's flexible, it needs flexibility and requires constant re-evaluation. And our levels of empirical diagnosis are important. We're uncertain of the effects of ARV coverage, and we have high rates of extrapulmonary TB, which were not factored in initially. So cost effectiveness, we don't think equals affordability or uptake or linkage to care. And this study that we did at a clinic really showed that we actually, to get 15 patients on treatment in the same day, we actually required 2 full staff members to shepherd the patient through the system. And that human resource at a clinical level is just currently not available. We then had to interface it with treatment guidelines, and you can see how complex the algorithm has turned out to be in South Africa. I think far too complex. If you're expert positive, rifampicin susceptible, you get regimen 1. If you are rifampicin resistant, you get immediate MDR treatment and referral for confirmation. The problem group are those that are HIV positive and gene expert negative. Those are the ones that cost us a huge amount. So we're going to have to really simplify this. There's going to have to be ongoing training and research and development. And some radicals like me think that there are a whole host of things we could cut out of this algorithm that would make it feasible and usable within the clinic. Results, we have detection rates that have ranged from 17% at the beginning of the program. We have 50% coverage to about 15%, which equates to over 100,000 cases. 7% of them showed RIF resistance with great geographical variation, which is of enormous concern for us. Comparing these to current diagnostics, we discovered we had 1 or 2 DST labs with problems, but that it compared very well the RIF resistance using both LPA and DST. And in our best sites, show sensitivities of about 95%. What is our problem, though, if we break this down, and I don't have time to do this, but the slides are for your use, is we're not yet getting adherence to the algorithm. And only about 40% are actually doing the algorithm in the fashion that it's been set up. So it's been not without challenges, but they've changed over time. We've got more confidence in the technology. We've managed to reduce our error rates nationally. Our clinical algorithm is still a problem. And we've had to address issues like calibration and connectivity, which have probably been some of the biggest successes. But health system strengthening is needed. How did we overcome the calibration? We did work with Cepheid and evaluated a remote calibration product, which will reduce the cost of calibration nationally by about 80%, and is done in the same fashion as you would run a normal test. We made up our own EQA, which saves us, it costs us about 32 Rand a distribution compared to about 320 if we got it through an international program. We've automated the analysis, so the verification of the instrument can be done immediately. The data goes, the statistical analysis is done behind the scenes, and you can be told that module 1 to 16 is fine. We've also worked on a remote connectivity project, which I think is going to be of great value. Is going to be of great value in continuous monitoring of quality as well as data. And at a glance, you can basically tell who's doing what where at any one time. So what have been the anticipated savings? Staff may be reduced when you don't have to do 5 million smears. Remote calibration costs have been important. Remote connectivity has saved costs. What has been unanticipated and underestimated have really been the fact that the clinical algorithm is so difficult to follow, the linkage to care, and we're still early in the program. The stock issues have also been, Cepheid have battled to keep up with the stock requirements for South Africa. I mean, they're managing, but it's a plainer day for us currently. And there are also enormous equity issues with phased implementation. We're having to speed up because everybody wants it, and everybody wants it now. They're not prepared to wait for the next phase. And so our total expenditure to date has been large, with high capital outlay. But what we do have is commitment. We had commitment from a huge number of donors, but we also had commitment from the Department of Health, and that was the most important thing. They were the first to put their money on the table, and they have committed to sustainability of the program till at least 2016. And I think I will probably stop there. But to just say to you that don't underestimate the amount of effort that goes into implementation. I could spend the rest of the day telling you about the detailed problems of implementation of both that first project plus the gene expert. I'm going to stop there and leave time for questions. Thanks.
Okay, I'd just like to thank Wendy for that presentation. Moving swiftly along to the next speaker. Next speaker is Cliff Barry, who is the Chief of the TB Research Section at NIAID, NIH, which is basically the intramural program at NIH. Cliff didn't give a title for his program, and I asked him before what his title was, but he said he doesn't have one. So it's basically TB and something to do with TB, I hope. Over to you.
Yeah, I think I did actually send a title, but I liked Ken's theme of not having a title for it for the session quite a lot. And so I actually, as you'll see, I sort of took that to the next level and decided nothing really needed a title. So as we go through the talk today, I've tried to make it visible to people even in the back of the room, and then I'm going to describe to you what I think the important points are. And I'm hoping this will sort of slow me down enough that I can convey to you what's interesting or what's not. Is this mic on? Can I wander? Yeah? Okay. So TB is a devastating disease still. There's 8 million new cases and 1.5 million plus deaths of tuberculosis. I always like to put a picture up like this to remind me of people I've known who died from the disease in different clinical contexts and in different settings. And of course, we worry more these days about drug resistance, but the simple fact is even drug-susceptible TB still is unacceptable, still has unacceptable treatment paradigms. The world that I work in mostly is involved in drug discovery and drug development for tuberculosis. But as you'll see, that sort of spans a lot of different areas. And the basic problem is that even though it's quite possible to cure people who are engaged in a clinical trial of tuberculosis, we have a 95% cure rate, it takes 6 months of treatment to do that. And 6 months of treatment in the real world, the world where TB is endemic and where TB is a real problem, is just about impossible. And this is just from a program that I worked on in Cambodia, where directly observed therapy was delivered to patients' homes in rural communes on the back of motorcycles on a small fleet of healthcare workers. And that's sort of the typical TB setting. And so 6 months of delivery of a drug is simply impossible in most of the settings where it's really urgently needed. And I'm not even talking about multi-drug resistant disease, which typically requires up to 2 years of total therapy. And so while we have a solution, and that solution sort of works in the best of circumstances, it's really far from ideal, and we need to figure out creative ways to approach that problem. And this is my best representation of the TB drug discovery pipeline. As you'll see, we have quite a leaky pipeline in place. And it leaks at all the 3 major places where we make decisions about drugs. It leaks at the point where we make in vitro decisions about drugs. This candidate is worth pursuing because it has these characteristics in vitro. It works when we make decisions based on our animal models of which things are worth taking into testing in humans at the second break in the pipe. And then it really doesn't work at all when we talk about how we actually test things in humans and how we're going to scale up that testing so that we approach reducing the duration of therapy with new agents that are currently in development. And so I'm going to just briefly touch on all three aspects of each of those leaks in the pipeline and tell you about at least some thoughts about how we've been approaching taping up those leaks, and then how we think the field could advance more and how we can actually shorten the course of chemotherapy. So fortunately, you've got a little time to recover before dinner, but this is a nice illustration of the magnitude of the problem. So this is a lung resection from a tuberculosis patient of ours in South Korea who's had resection surgery because they had extensively drug-resistant disease. It's not uncommon. In fact, it's pretty common in South Korea to operate on people if it's possible to do that. It's about the best thing you can do to really help a patient with XDR disease. And I like the picture because it really illustrates how complex the disease is. You don't have to be a pathologist to appreciate this. It's a mess, and there's a lot of different kinds of processes going on. You can see in the box, you can see that the lung is sliced down the middle, and that slice in the black box that surrounds one of those is the center of a cavity. Okay, so you've got everything from these cheesy looking, and literally that's what caesium means, cheesy looking, caseous lesions that are where the arrow is pointing, to these surfaces of a cavity which is well aerated in connection with the air system where the bacteria are thought to be rapidly multiplying. And all of these different environments have very different consequences in terms of what the bacteria is experiencing at that point in time. And they have very different consequences when you think about how you're going to get a drug that specifically addresses each of those different bacterial populations. And so the thought, at least the thought that has dominated the field for the last 50 years, is that really when we're putting together combinations to try to address the duration of chemotherapy, we're trying to address multiple different populations of bugs within a single patient, all of which have very different physiologic states, some of which may be non-replicating, some of which may be not very well connected to the circulatory system. So we have all these different microenvironments as we think about them to address. And those microenvironments have very specific names, and I'm not going to bore you with any of the names of them. I mean, the sort of prototypical, beautiful textbook, and this really did come out of a textbook, lesion that a tuberculosis forms is called a granuloma. Sometimes it's caseous on the inside. Sometimes it's mineralized, where calcium has actually deposited. There's lots of fibrosis typically around these kinds of lesions, not all of them. And again, the picture of that patient's lung was meant to show you that they all occur at the same time in each individual patient. And so you've got all these processes and all these different microenvironments, and how do you address those in the context of a drug discovery program? And one of the physical consequences of that is also the connection between the bloodstream and those lesions. And so this is actually a reconstruction of a CT scan of a patient with tuberculosis. And you can see various pathologies here. You can see these light blue speckly lesions, these red sort of less dense lesions. Then you can see this big red cavity that's in the patient's lungs. And you can see how some of those lesions are actually right at the bloodstream. The green is the blood vessels in the lungs, while some of them are quite removed from them. And in fact, if you look at the pathology literature carefully, you see many of them are not even connected to the vasculature at all. In fact, they seem to have collapsed the vasculature that's near them. So that means when you're trying to get a drug to a particular lesion, you have to worry about whether the bloodstream is actually feeding that lesion and how well your drug is going to get within that lesion at the end of the day. So does it make a difference? This is a summary of about 30 patients. And again, I don't want to bore you with the details of what the different categories are. There's 10 different categories of abnormality that those patients can have, and they're radiologically characterized categories. And this is a summary of 4 expert radiologists reading those over time, a 6-month period of time while those patients are being treated with chemotherapy, and then whether those abnormalities are resolving or not. And so some abnormalities resolve very quickly. That's the green color, and that'd be loose abnormalities, typically consolidations or loose kind of
ammonia-like infiltrations. And then dense abnormalities like cavities don't respond at all in that period of time. And that fits perfectly with what we know from large drug studies, where the lesions that people relapse because of are almost always cavities. And so cavitary disease is a predictor of bad outcome, and is also a risk factor for developing relapse disease in the end. And so learning how to address what's in a cavity really is an important aspect of TB drug discovery. And so we did a kind of a wacky test of this to sort of see how well we could translate this all the way back to the bench in terms of what was happening, how our screens were run, and what we were actually looking for in a drug candidate. And so, again, you don't need to look at the details. We sort of start with a standard growth medium for TB, which is how we screen drugs, right? We screen drugs against TB grown rapidly in the best, most nutrient-rich environment we possibly can get, none of which are probably available to any of the lesion subtypes. And then we swapped out bits of that media sequentially and forced them to grow on substrates that probably were present in the lung, like lipids, cholesterol, low pH. We tried to mimic as best as we could the physiologies that might actually be present within the lung. And then we took a deck of 15,000 compounds. It doesn't sound like a big number, but we didn't do a normal kind of screen. We did a screen where we did dose titration of each of those 15,000 compounds in 10-point dose titration. And so we measured the MIC for 15,000 compounds in 12 different conditions. And we said, okay, if we had run this screen, what compound would we have actually come up with? What would have been our hits from that compound? And this is what that data actually looks like. This is a box plot showing you all 15,000 compounds, all 10 concentrations, and then the active compounds are the ones that show the blue line. And the blue line is an IC50 curve, essentially, for it. And so we can measure the IC50 and say, under this particular condition, how good was that compound? What was that compound, and how did it look? And the answer is not surprising to any of us, but I think it's been surprising for people in the field to understand, is what you get really depends on what the bacteria feels at the time. What's its nutrient source at the time? And so this shows you the aggregate MICs now, and blue is very active. And yes, there are some things that show up as active across no matter what the growth condition the organism experiences. But then you can see there's huge bands of things that show up as active only under certain specific conditions. That makes sense physiologically because the bacteria has a different metabolism and is differentially susceptible to antibiotics under different conditions. But it's a really important point because, we only screen using this one condition here. So anything that's blue other than this is something we would never pick up in a high-throughput screen against tuberculosis. So we really need to think more about our screening conditions and try and create screening conditions that are customized to the type of bacterial metabolism we're trying to interfere with. So I'm technically from south of the Mason-Dixon line, so I firmly believe that you can fix anything with duct tape. And so we think we've fixed a little bit the first problem in the TB pipeline. What about the second problem? The second problem is really after we've done our screen and the chemists have had a play with the molecules and we have something that we want to test as a potential candidate drug, we have to use an animal model. And really, our animal models are less than ideal. And I had to promise several people I wouldn't say anything bad about the mouse in this. So I'm only going to say good things about a different animal model that we've been working on that I think addresses this difference. And so this cute little guy is a common marmoset. It's a New World primate species. It has a number of advantages. This is really, you can tell I'm a chemist because this is really a chemist's animal model because this is a small monkey that weighs about what a laboratory rat weighs. So it's about 250 grams as an adult. That's important because that means you don't need to make very much compound to do the animal study, which is typically why people shy away from primate studies. It's also true that 80% of births in this species, for some unknown reason, are identical twins, which is also a serious advantage if you're looking at an outbred animal with different kinds of chemotherapy regimens, and you really want to do it precisely. Every animal is born with its control as a litter mate, and so you can really do very tight comparisons in this animal species. So we, at the time we started this several years ago, we didn't even know if you could infect common marmosets. So we learned how to infect them. We learned that the disease they developed looks very much like human disease. And we learned how to deal with them from a husbandry perspective and from a drug dosing perspective. And we learned that, in fact, what they developed looks exactly like human disease and responds almost identically to human disease. And I'll show you a little bit of that later. And I'm going to just sort of jump into the PET CT scans without explaining it, and I'll come back later and explain it when we're looking at some human data. And so these are two identical twin animals. They were both infected with Mycobacterium tuberculosis. And this is an untreated animal who's developing progressive disease. He doesn't have a 12-week scan because he died from the disease before he got his 12-week scan. This is his identical twin brother who was treated with standard TB chemotherapy. This is what every patient in the world gets with drug-susceptible disease: isoniazid, rifampicin, pyrazinamide, and ethambutol. And that's the kinetics of their response. And I'll show you later the kinetics of the response in humans, because we have tried at every level to mirror experiments we're doing in monkeys with a corresponding experiment in people so we can make direct comparisons between the response rates. What's nice about the PET CT scans is we can immediately derive quantitative estimates of what's happening in the animal by looking at the amount of normal lung and diseased lung in those animals. So you can make quantitative comparisons and comparisons between twin animals in a quantitative sense. And that's important because you want to be able to compare regimens. And what you're trying to do is develop something. The problem isn't that we can't clear patients' sputum very quickly. The problem is if we don't keep treating them after 2 months, if they've cleared their sputum at 2 months, if we don't keep treating them until 6 months, then they develop relapse disease within the next year after you take them off of drugs. And so to really get a handle on whether the model was telling us something that was relevant to relapse disease, we chose 2 regimens that were used in the the British Medical Research Council East Africa trials in developing what is our current standard of care therapy. And those 2 regimens were the 4-drug combination that's been adopted as standard of care, and then a regimen that experienced of just isoniazid and streptomycin, which was one of the early regimens run in the East African studies, where patients had a very high rate of relapse. So 70% of patients treated with that develop relapse disease. And what you can see is that isoniazid, if we look at just superficially at the amount of bacteria per gram of lung tissue, isoniazid, the 4-drug combination and the 2-drug combination look identical. If you look in the spleen, isoniazid streptomycin actually looks a little bit better. In the liver, it actually looks a little bit better. And so based on the animal model, could you pick the regimen that was going to give you a lower relapse rate? And the answer is, based on that, no. But when we take the animals apart and we look at what's happening within those specific lesions, what we can see is that in granulomas proper, the treatment is identical between the 2, but it's actually within the cavities that there's a big difference. And the big difference here is the HRZE sterilizes the cavities, and streptomycin isoniazid doesn't sterilize the cavities. And so again, that corresponds exactly with the major risk factor for development of relapse disease in patients treated for tuberculosis, the presence of cavities. So the model in that sense reflects exactly what we would expect to see in terms of the sterilization potential of a new drug regimen. And of course, because it's imaging and it's quantitative, we don't even need to sacrifice the animals to be able to tell that. And so this just shows you the total volume of involved lung in animals, a group of animals that are infected with tuberculosis, develop disease, and then at week 6 are treated with either HRZE or streptomycin isoniazid. And again, you can measure directly the dense lesions, and you can tell from the CT what's a cavity. And so you can immediately get a readout of how good your regimen is, and then at what point could you potentially stop treatment. So that's great. And although I tried to avoid words, I had no problem putting chemical structures up for you this evening. And so this is an important molecule to us, but it's a definite love-hate molecule. So this is 2-deoxyfluoroglucose. This is FDG, and people who've worked in oncology will recognize this because this is a molecule that's used routinely to scan cancer patients, and it's in a PET scan sense. The reason it works is it's trapped by metabolic metabolically active cells. It's phosphorylated and can't get out of the cells. So what you're looking at is a picture of the host metabolism, not the bacterial metabolism. I've shown you a couple of PET scans, but I needed to explain this to you so that you understand PET's not specific. It can be a process, it can be any inflammatory process that actually gives rise to a PET signal. And this probe, although it's very useful in TB cases so far, is not a perfect probe, but it's an imperfect probe that actually seems to work. And so this is showing you that I showed you that after 2 months of treatment, I could tell you who was getting better with HS versus HRZE. These are the changes in PET scans in those animals after only 1 week of treatment. Here's an untreated animal, showing just sort of noisy variations in the PET. Here's an animal treated for 1 week with isoniazid or 1 week with rifampicin. And the bulk, not one animal, sorry, many animals, the bulk trend in both those cases is down. So it's an early marker of what's going to happen in the future in those animals. How well are they responding to the treatment? And can we develop that as an early marker for what's going to happen in people? And before I leave that, I want to show you one more picture that this is an animal just immediately before it's being treated. And this is after only 1 week of treatment with this molecule, which is one of my favorite new oxazolidinones, and that's linazolid. And what you can see is that, and I don't have time to go into a lot of the data, but that this really is remarkably effective in this model, which distinguishes this model from other animal models where linazolid shows much less effect. So we've at least attempted to fix the second break in the pipeline. Let's talk about the third hole. And so the basic problem is that our next step, our first step when we go into humans, is always something called an early bactericidal activity assay. And so in this assay, what we can do is give monotherapy to patients for up to 2 weeks typically, and we measure the CFUs quantitatively in patients' sputum, and we watch the fall in the CFUs in the patient's sputum. And if you use that sort of an assay, you're only looking at sputum-borne organisms and only a subset. And if you use it to sort of rank the top TB drugs, our component of quadruple drug therapy for TB patients, isoniazid has the highest EBA, rifampicin has the second highest EBA, and then ethambutol and pyrazinamide actually have very minimal EBA. Now, if instead, based on the British Medical Research Council trials in Africa that developed this regimen, if you rank them in terms of sterilizing potential, rifampicin is the most important, pyrazinamide the second most, INH and ethambutol not so much. And so you don't get a rank order that predicts efficacy in humans in terms of relapse disease from an EBA study. We all do it because we don't have an option, because we need to place the drug somehow, but it's really an imperfect measure of drug activity. And so in about 2005, we started first looking at patients. We actually did this before any of the animal studies. And this particular fellow is an early patient of ours who, in my mind, is to my knowledge, is actually the first TB patient who ever sat down intentionally and sat on the double ring of a PET CT scanner. So the first ring is here, the second ring is behind it. So it's a CT physically linked to a big detector of radiation. He got a bolus of FDG an hour before, and then he got this scan taken that actually allowed us to look at the metabolic activity of the disease inside his lungs. So I'm going to talk to you about first the CT results and then the PET results. So the CT results, we spent a lot of time arguing with radiologists and relearning bad lessons from the cancer field, and instead found it much more productive to look at it from an image analysis perspective. So this is actually that guy's scan. So here's his full scan in 3 dimensions. And then we developed software that allowed us to sequentially strip off that scan layer by layer until we got down to the lung region of his scans only. And so without any human intervention, a computer does this, a piece of code does this. We can strip out lungs from those scans. And what's inside of those lungs looks like this. It's mostly air, of course. Lungs are mostly air. But in a TB patient, what you can see is that in addition to the dense vasculature, the blood vessels that are present, there's all these lesions. And so this is not atypical either. I mean, typically there's thousands of lesions in patients, right? That's a very large number of patients. Now, because we can look at this very precisely and quantitatively now. What we can do is say to the same patient over time what happens to that disease. And so this is showing you the patient's abnormal lung volume. So this is a measurement of radiodensity. And this is hard tissue. So this is the abnormal volume in this patient, a new patient with multi-drug resistant disease. At the time they entered the study, it's about 200 mils of volume. 2 months later, it's about a little bit less than that, 10-20% less. And 6 months later, it's down around 50 mils of total disease. And it's a nice because it's a quantitative, reader-independent measurement of what actually happens. And if you look at a cohort of patients, and again, we started this about 5 years ago, but this kind of analysis has only been possible recently. We take those patient scans in the first 6 months, the first 2 months, those changes, and we look 3 years in the future, after they finish their 2 years of chemotherapy and then stop taking drugs, and we watch them for another year, and we say, okay, who develops relapse disease versus who doesn't develop relapse disease, we can predict that pretty well. And so this is the people who responded. They had this total volume and change in their TB disease. And these are patients who failed to develop, developed relapse disease subsequently in the future. So that's nice. It's 2 months, and it's quantitative, and it's not dependent on very finicky microbiology, and it's not noisy data. It's very clean data, actually. But let's talk about the PET changes. So this is a patient. I promised I would show you a patient from on quadruple drug therapy. This is a PET CT scan of a patient from South Africa on a study we're doing with Gerhard Farzelitz at Stellenbosch University, and showing he's got very extensive disease. This is drug-susceptible disease, though, fortunately for this patient. He takes quadruple drug therapy. 28 days later, he has a repeat scan, and you can see the magnitude of the change. And you can measure the magnitude of the change. But I mean, it's very visually obvious to this. And I think we haven't tried it at 1 week in patients, but I showed you the data from 1 week in animals. We think we can measure it much earlier than that, although we're still validating that as a marker of extent of disease. Again, because we have small patient cohorts, I'm not claiming this is a validated marker, but it definitely looks promising. This is a cohort of patients and the percent change in their SUV 2 months after starting MDR therapy, and then patients in green who all had a successful cure, and then patients in red who didn't have a successful cure, died or failed to respond to chemotherapy. So we think that's a quite promising biomarker and surrogate for our current kind of EBA studies and looking at the response to therapy, and potentially will allow us to begin to approach treatment shortening in patients in a prospective sense, comparing regimens based on a meaningful outcome. And the other reason I say that is because that's important is illustrated here. So this is not my data. This is actual EBA data. And this is a drug called linezolid. I showed you the monkey treated with linezolid before. And this shows you the EBA activity of linezolid over the first week of patients on study. This is isoniazid, by the way. And look at those error bars. So it's really noisy data. But the conclusion from the EBA study was this drug has no place in treatment of tuberculosis patients. We didn't listen to the EBA study, though. I listened to my very experienced physicians in Korea who were treating patients with linezolid and having seemingly miraculous results. We did a study in patients with extensively drug-resistant disease where we randomized people to be hospitalized and then immediately start taking linezolid, or wait 2 months and then start taking linezolid, and affected an amazing 90% cure rate in those patients, or transformative rate in those patients. And yeah, I'm almost done. And this is just typical of those results, and shows you a patient who was in the delayed arm. So this is his baseline scan. This is 2 months later, when all he's done is eat bad kimchi in the hospital for 2 months, and then he starts taking linezolid, and 6 months later his disease is gone. This is a 23-year-old boy with totally drug-resistant disease. I watched his father and his sister die from TDR disease, and he's checked out of the hospital, cured for the first time in his life in the last 11 years that he's had the disease. You know, this was a remarkable result for a drug we would have totally missed if we used our standard pipeline to get through to a new drug. And we could tell as early as 1 month in those patients that this was going to be a remarkably effective drug. Another patient with totally drug-resistant disease who 1 month later got a rescan, and we can quantitatively show you that linezolid is working very well in these patients. Okay, so I'll skip that and go to the final Band-Aid to the pipeline. I'm not saying it's all fixed. I'm just trying to show you our solutions, or our approaches to solutions for fixing the TB drug pipeline. And hopefully, in the future, you'll see more substantial numbers of patients and more validation of these approaches and more integration of this all the way back to the lab. So thank you very much, and I won't take questions.
Okay, thank you very much, Cliff. Moving straight on to our final speaker this evening, who is Professor Sangeeta Bhatia, who's from Massachusetts Institute of Technology, and she's also a Howard-Hughes medical investigator. And the title of her presentation is Microscale Liver Platform for Liver Stage Malaria.
Hi, everyone. Good evening. I recognize that the hour is late, and I'm standing between you and a nice glass of wine, so I'll try to be succinct. I wanted to start just by saying what a privilege it is to be here. I'm a real relative newcomer. I've been working in malaria for only 3 years, and it's just an honor to be here amongst so many of you who've made so many contributions in the field so far. So what I'm going to be telling you about is I'm a bioengineer. And most of my lab is actually dedicated to making big transplantable pieces of liver tissue for patients out of billions of cells. And over the years, we've learned now how to manipulate hepatocytes, liver cells. And what I'll tell you in the next 20 minutes or so is that some of those lessons can be applied to making miniature livers. We call them microlivers. And we think they might be useful platforms for growing human pathogens for drug discovery. Okay, so just to set the context, I don't have to really do this for most of you, but just for completeness. I just wanted to sort of remind you where we are. So the deaths by malaria are decreasing over the last decade, of course, due to all of your collective efforts. We still have over 300 million cases a year. And I really use this slide to emphasize the difference between Plasmodium falciparum, which is more virulent, and Plasmodium vivax, which is more chronic. And vivax has in particular this pattern, which you've all heard about, which is that it relapses. So there's a dormant form of the parasite that can stay in a latent form in the liver and reactivate months to years later. And as we turn our attention forward from the decrease of malaria deaths toward by drug regimens and potential vaccines to eradication, we have to really contend with this issue. This, I think, really came to light. This is getting cut off here. This is a slide I borrowed from Alan McGill in this Lancet paper in the year 2000, where this eradication attempt was done in the Southwest Pacific. And I think what's really striking about this eradication effort was that 718 inhabitants on the island, when they started with mass drug administration and insecticide-treated bed nets, there was more falciparum than vivax on the island. There was good compliance, and falciparum was gone in a year. Vivax took 5 years. Okay, so this is what we need to contend with, and the truth of the matter is we still, at the moment, we only have 2 drugs, primaquine and its newer cousin tafenoquine, that can eliminate this dormant form in the liver. And those 2 drugs, as you well know, cannot be administered in many endemic regions because of the risk of hemolysis in G6PD deficient patients. So we need new drugs for this hibernating form of malaria, of vivax. Okay, so for that reason and several others which I'll outline here, there's been an increasing interest in looking at the liver stages of the human malarias. And again, this is just a life cycle that you're all well familiar with. So when the mosquito bites a human, the sporozoite, which is at about a 1 micron worm, homes in on the liver. It's really interesting. There are 220 cell types in the body. It only infects the hepatocyte, and it only infects human hepatocytes, and that will become important later. There it sets up shop and it amplifies tens of thousands of times, where then it bursts out as a merozoite and starts the blood cycle that gives the characteristic symptoms of malaria. Okay, so this is an important stage, and it's become interesting because it harbors these dormant forms of vivax. which is a barrier to eradication. It's an exciting stage to target of the life cycle of the organism because there's a relatively small number of parasites at this stage, and there's only one round of multiplication. So unlike the blood stage, you don't get bursting and reinfection and multiple cycles of amplification. If you could block the parasite at this stage, that also would prevent clinical symptoms and prevent transmission to the mosquitoes. The other interesting thing, which I'll touch on at the end of my talk, is, of course, that some vaccines, the pre-erythrocytic vaccines, are targeting this liver stage because attenuated sporozoites that can enter the liver and raise an immune response can then potentially protect against subsequent infection. Okay, so for all of these reasons, we need human liver stage models of the human malarias. Ideally, that would last for weeks to months. Now, why do I say that? The earliest known relapses clinically of Vivax are at a month. So if you really want a model of relapsing malaria, you'd like a liver stage model where the organism can go in, some of it will burst through to the liver stage, some of it will hibernate, and in a month you'll have that reactivation. So that's sort of the goal. Okay, so what do we have available? The current models are actually pretty limited. I know that I loved the last talk with no words on the slides. I was wanting to redo mine as I was listening to it. But the first 4 rows in this table are really the workhorses of the field, and these are what's been done primarily. So these are human cancer liver cell lines, hepatomas, that are utilized, largely the HCO4 cells and the HepG2 cells. And what you'll see is that they can be infected at low rates by both falciparum and Vivax. They don't support complete life cycles of the liver stages particularly well. And furthermore, they don't capture a lot of the host biology. That's not really surprising. I think if you think about the main difference between a human hepatocyte and these cancer cell lines are dividing every 12 to 18 hours. And that's where the parasite is setting up shop, making its happy home. A human hepatocyte doesn't divide, maybe once a year. Okay, so that's the big difference. There are lots of other differences. They're genomically unstable. They're not polarized. They don't have drug metabolizing enzymes to any significant degree. So they're inadequate for lots of reasons. So when I first came to this field, I was invited to a liver stage meeting in Seattle at the Foundation. And I met the author of this beautiful work, Dominique Mazier, who had done these seminal papers in the 80s. And she had taken primary human hepatocytes and shown that she could capture the full life cycle of falciparum and Vivax in vitro all the way out to the blood stage. So she could overlay these cultures with blood, the parasites would go in, progress all the way through the liver stage, and then burst out and infect the overlying blood. So I asked her, why doesn't everybody do this? And she said, well, it turns out I have an operating room with fresh human hepatocytes next to an insectarium with fresh falciparum and Vivax. These two things are co-localized. That happens almost never anywhere else in the world. So those are, for an engineer, that's kind of music to my ears. Those are technical reasons. There is no fundamental biology reason why this can't be done more reproducibly. So since her work in the 80s, a significant advance has happened in the human hepatocyte literature, and that is the field has learned how to cryopreserve human hepatocytes. These advances were largely driven by the drug discovery interest of pharma in characterizing the metabolism of new compounds. And so the finding has been that you can take human donors, human livers that were consented for transplantation, but not transplanted. You can procure those hepatocytes and freeze them, and 1 in 10 donors can be thawed in a way that they can be plated and cultured. So 90% of the time it doesn't work, but 10% of the time it does work. And now there are vendors all over the world, and 6 here in the US, where you can actually procure these cells. Okay, so that's an exciting advance, and that means that we don't need the OR anymore. We don't need the operating room for the fresh human hepatocytes. We can use frozen human hepatocytes. What's the problem? The problem is when you put them in culture, as you can see this in the back of the room, they rapidly lose their liver-specific functions. So this is just one of the 500 liver-specific functions the liver does. You can see their morphology here. They start out happy. Here they're plated on collagen in culture, and they become what we call fibroblastic. So they rapidly lose the whole repertoire of functions that you're interested in. And so we were well familiar with this problem because, as I said earlier, we were trying to build an artificial liver that captures all of these 500 functions and that could be transplanted into patients. And so we need to figure out how to make these hepatocytes happier. And our approach was as follows. This is the microarchitecture of the liver. This is the beautiful home of human hepatocytes in vivo that they've been now isolated from by collagenase perfusion and plated in culture. And if you zoom in on it, you see the hepatocytes are in this highly organized cord-like structure where they have cell interactions with themselves and then with several other cell types. They interact with extracellular matrix, and they interact with gradients of nutrients that are coming through the capillary of the liver, the sinusoid. So this is a microenvironment of the liver that's been disrupted, and our approach is basically to try and mimic this in vitro using tools that allow us to manipulate the microenvironment. And these are tools that you all have been hearing about throughout this whole meeting in the diagnostics platform. So these are the tools of microfabrication and nanotechnology that have been advanced largely for computer manufacturing and turn out to be wonderfully good at manipulating cells and molecules from the sort of 100 nanometer to 100 micron length scale in culture. So you can take one cell and put it right next to another cell, right next to a particular extracellular matrix molecule, inside a gradient, recreate the microenvironment that you think is important, and then ask what happens to the hepatocyte phenotype. So that's what our program has been interested in doing. And I'm only going to tell you actually about one cue today because we think it's the most important one, and that is the interaction with other cells. So when I started this work as a graduate student 20 years ago, we were building on the work at the time of another amazing French researcher, Christiane Gugen-Guillozo, and she had made this finding. Here, the hepatocytes now are labeled red, and we've added another cell type here labeled green. What she showed was that if you co-culture, if you add another cell type next to the hepatocytes, in her early work she took other non-parenchymal cells from the liver, but other groups have since shown that many fibroblastic and mesenchymal cell lines will have the same effect, that you could transiently rescue the phenotype of those cells. So instead of that decline I showed you earlier, you would get rescue. And what I did as a graduate student, was to then go on to organize these co-cultures of cells on a surface by micro-patterning the two cell types. So what we did was take cover slips, put collagen stripes on them instead of a uniform coating. The hepatocytes would then stick on these collagen stripes, and then we could fill in the bare areas with the second cell type. And doing this manipulation, we were able to control the amount of self-homotypic interaction and heterotypic interaction. And we were able to tune the amount of rescue and the duration of the rescue in these co-cultures that one would see. And so this is just an example. If you do this for rat cultures, what you find is a particular optimum, a particular ratio that's optimal, a shape, a spacing, and so on. And you find similar things for human, that is that you can identify an optimum, and that you can take these cultures out now for a very long time. So whereas random cultures were transiently rescued, as I mentioned earlier, these micropatterned rat co-cultures survive for upwards of 2 months, and the human cultures now for about 4 to 6 weeks. Okay, so I'm getting to malaria. I'm almost there. Okay, so then we wanted to create a technology that might be useful for real biology and maybe even medium throughput drug discovery. And so the cover slip technology that I described, that I developed as a graduate student, of course, was not scalable. We had to reinvent this a couple of times. And now we have a manufacturing method that basically allows us to stamp these collagen spots into a regular 96-well plate. And if you zoom in on one of these wells, you'll see that for these particular human microlivers, we have these colonies of 250 human hepatocytes, which is their optimal size and shape and spacing. And they're surrounded by our favorite supportive non-parenchymal cell line, which happens to be a subclone of mouse embryonic fibroblasts. And that, instead of the hepatocyte phenotype declining now, it's rescued for about 4 to 6 weeks. And if you just zoom in on one of these colonies, for those of you who had the Netter anatomy textbook in medical school, there's a beautiful picture of the chicken wire network of the bile canaliculi between the hepatocytes that we see in vivo. And I just love this image because this is an image of MRP2 transporters in our livers lighting up that chicken wire network. And it probes the whole polarity axis and kind of in one shot. So we've characterized these extensively. I've told you there's 500 functions in the liver, and so we had to characterize them pretty extensively to claim that we were capturing the human hepatocyte phenotype. And I just want to mention a couple of things that are relevant. So in addition to the characterization of them, one question you might ask is now how representative are these human microlivers of clinical responses, of patient responses? So one thing we've done we had to spin out a startup company that could actually work on the manufacturing of these and get them into the hands of pharma to do these experiments. And one thing we've done is now worked with, this is a collaboration with Pfizer, is to work with companies that had libraries of compounds that had been in patients where they had trouble doing things like metabolite ID or drug-drug interaction or toxicity prediction in a, let's say, a library of 100 compounds, as is in this case, and then rerun those through our human microlivers and compare them to the animal data that they had previously and see how much better this model was potentially at calling those interactions. And you can see that we're better at calling metabolite ID in a variety of categories. We're better at hepatotoxicity predictions. If we make rat microlivers and human microlivers and we give them drugs that we know have species-specific responses, we see species-specific responses recapitulated in these in vitro microlivers. And then after we did this, we got interested in, well, what else could you do with a human microliver that was challenging for the field before? And that's when we got interested in pathogens. So the first pathogen that we worked on actually was with Charlie Rice at the Rockefeller University, and that was hepatitis C. And hepatitis C is another one of these pathogens which is commonly grown in a cell line that has all kinds of deficiencies. And so what we did with working together with him was establish a persistent hepatitis C viral infection in these cultures. So this was quite exciting to us, and this is the time that we came to the malaria field. Okay, so I told you that we can now take cryopreserved human livers and put them into these systems. And so in order to do our first malaria experiment, we wanted to pick a donor that would be readily infectable with a human malaria. And most of the data I'm actually going to show you is going to be with Plasmodium falciparum because that's been our workhorse while we're trying to get the vivax sporozoites coming. So we took 8 different donors from a variety of ages and ethnic backgrounds and put them into our system and tried to score them for infectability. So across the top here is just a lot of data that should show you that they all get rescued in this assay when we query them by albumin production or nitrogen metabolism or P450 function. So for 21 days, all the hepatocytes are rescued in these micropattern co-cultures. And then we started to look at them for what we thought might be interesting biomarkers of infectability by the human malarias. So the first thing we wanted to look at was CD81 expression, which is one of the known receptors for Plasmodium falciparum. So we stained these micropattern co-cultures, and you can see this nice membranous staining here. And we scored, of the 8 donors, we scored them, you can see the high staining ones here in red. And it turned out, and then we infected them. So here we're looking at Plasmodium falciparum infection, and you can see that the CD81 staining did not actually help us predict which ones were infectable with Plasmodium falciparum, because this guy had lots of CD81 and was not very infectable. So of the 8 donors, 2 were quite infectable, so we were excited about that, and then we went on to further characterize it. We wanted to try one more time to see if we could find a surrogate to picking out infectable donor lots other than actually infecting them with Plasmodium falciparum sporozoites. And so we looked at P. burgii infection, which was really not predictive. This is a rodent malaria. And a second rodent malaria, P. olei, which is thought to be dependent on that same entry receptor, CD81. And this is actually a pretty good proxy, actually, for the human malaria. So that was kind of exciting to us. I should say it's cut off here that this work was all done in collaboration with Scenaria. These are cryopreserved Plasmodium falciparum sporozoites of the NF54 strain. Okay, so do these microlivers support the full life cycle of Plasmodium falciparum like Dominique Mezgier's early papers? So these are now experiments walking through how we do them. So we start in a 96-well format. We have about 10,000 hepatocytes in each well. We add the cryopreserved sporozoites, and we score them for viability using a gliding assay. So in the particular data that I'm going to show you, about 25% of these were actually gliding. So we start with, this is just one colony of a micropattern human hepatocyte here. And you can see, I don't know if it's projecting well, but here's a little sporozoite leaving its little CSP trail on a surface, and so that's how we score their gliding. We then actually look at how good they are at traversing multiple hepatocytes, because they traverse multiple hepatocytes on their way to setting up shop and growing into a schizont in just one hepatocyte. And we do that using an assay that Maria Mota taught us, which is a high molecular weight dextran that you add to the media. And when the membranes are wounded, the dextran seeps into the cells, and then you can fix and stain it. So basically, this is a track of all the hepatocytes that were injured by a sporozoite along its way. We can fix and stain these cultures and see how many get in versus how many stay out. We see about 10% of the sporozoites are actually inside the hepatocytes. And then we can fix the cultures over time. So at day 3 and day 5, and for those of you who are used to looking at extra erythrocytic forms or schizonts, we think these are nice, big, juicy forms. I'll show you quantitative data in a moment. Growing inside hepatocytes, this is a hepatocyte nucleus, and growing bigger every day. And then finally, we overlay blood in these cultures, and we see at very, very low parasitemia, we do, in fact, see infection of the overlying human blood and completion of that cycle. Okay, so very rapidly, the two team members who are working on this project got tired of staring down the microscope and counting these little tiny forms. So one of the very first things they wanted to do was automate this. So we worked together with the Broad Institute to come up with a machine learning algorithm that would allow us to automate. Basically, you train the algorithm, and now we can run these routinely through the algorithm to automatically count these potential parasites in a culture. And these are the kind of data we get. So at day 3 in culture, we see an average schizont size of about 10 microns. And at day 6, we see about 20 to 25 microns in size, and some of them are larger than 30 microns. I should say that these are not as big as one sees in vivo, but bigger than one sees normally in vitro. So we're sort of somewhere in between. If we compare these to what grows in the cell lines in the field, one thing that's interesting about this is that the infection rates that we see, the number of initial infection events in our human microlivers as compared to the human cancer cell lines like HCO4 are about the same, actually. So we're quantitatively not much better if you just look on day 1 at infection. But if you look at how many of the sporozoites progress all the way through their life cycle, you see a much higher progression rate in these human microlivers than you do in the cell lines. And if I hypothesize that, again, that's because of the proliferative environment. This is a busy slide, but we wanted to also look at the drug metabolism environment of these human hepatocytes as compared to the cell lines. So we're working with colleagues at the Broad. They developed a bead-based Luminex assay for us of all 83 drug metabolizing enzymes that are present in the human liver, and that allowed us to profile 2 cell lines that are used in the field, the HepG2s and the HCO4s, as compared to our micropattern co-cultures and then just hepatocytes alone. And basically what you should see is that there's a lot more drug metabolizing enzymes present in our human livers. And we think that's particularly important for drugs like primaquine. So primaquine is a drug that you all know better than me, has an active daughter metabolite. And so some of these things are going to be missed in the absence of enzymes that actually do bioactivation. And an example of how this plays out in this system is if you add primaquine to these cultures and then you just look at primaquine clearance over the first day, you can see that the micropattern co-cultures clear a lot more of the drug due to that drug metabolism than the cell lines or hepatocytes alone. So this is an indicator that they're actively metabolizing these drugs. So one question I get all the time is what's up with the cryopreserved sporozoites? How much do they really reflect what we know about malaria biology? And so we just recently got together with Scenaria, drove down to Rockville, Maryland, and did a side-by-side comparison of the fresh versus the frozen malaria from the same lots. And what we see, and I think what many of my colleagues predicted, was about an 8-fold increase of infection when we use fresh versus frozen falciparum. So that's nice. We know that we can boost our infection rates by using fresh falciparum. I will say that from we start thinking about actually how to run a drug screen, the truth of the matter is you still want a QC reagent that has very low variability. So what we see is that even the cryopreserved falciparum has pretty 4-fold variability in infection rates. If we just pick our favorite falciparum cryopreserved lot and our favorite human hepatocyte donor, then we get very nice tight coefficient of variance. We can come back day after day after day and get almost exactly the same experimental result. And now using the automated readout, we're starting to get things that look like drug responses. It's not 10-point drug dosing yet, but here we're looking at primaquine drug responses and atovaquone drug responses, and you can see that atovaquone is comfortingly much more potent than primaquine, as it should be in this assay. So what about Vivax? So I just want to kind of remind you where I started. So this is kind of what we know about our system. It can live for about a month, sometimes with a good donor out to 6 weeks. And up here is a map of what should happen with Vivax biology. So in the best kind of relapsing conditions, let's say it's a Chesson strain of Vivax, you'll get some that should grow through to the blood stage, some chysons, and some that should become these hypnozoites, these dormant forms. And after a month, in the best case scenario, they might reactivate. So we're sort of right on this cliff of where we think it might work if the livers live long enough and we could get the hypnozoites to reactivate. We might start actually seeing that in these cultures. And so I always make this plea at malaria meetings. If any of you have ideas based on your clinical observations about what we can do to wake these hypnozoites up, please let me know. We've heard things like nutrient stress, temperature. Right now we're just looking at them and I'm wondering, are you a hypnozoite? We're staining them for different things. So I welcome any ideas on that front. Okay, so this is what they look like. So these, we've had 4, I'm in Canada, I can say this, we've had 4 shots on goal. That's a hockey analogy. Some people are laughing. We've had 4 chances to do the Vivax experiment. Vivax is very hard to come by. This was our first result with Scenario. This is an Indian strain. And essentially, this is what you see. So here we're staining for CSP. So you see that we're getting some infection. The forms are getting bigger. On day 12, we see some big forms and some little forms. These are the so-called small forms. They might be the so-called small forms or the hypnozoites. And then if you wait, if you look out on 21 days, you only see the small forms. These big forms here stain for multiple markers, like you would expect them to for the large forms, the merozoite surface protein. So this is suggestive. I can't say more than that about what these are. We did this again recently. This is actually a Chesson strain, so this is one of those rapidly relapsing strains. And you can see we're getting better at our microscopy. So on day 6, we see some nice juicy forms, and again, some small forms. And we're starting to see enough of them where we can quantify things. So we can see, on day 6, we have some big forms, and on day 21, everything is little. I can't say whether the small forms are hypnozoites or not yet, but again, I welcome your ideas, and it's sort of tantalizing that they might be. We'd like, obviously, now to do drug sensitivity experiments on these small forms. So the key experiment would be to do primaquine versus atovaquone, because primaquine should kill the small forms differentially. So that's what we're gearing up to do if we can get more Vivax. Okay, so that's what I wanted to say about the drug applications. I just have 2 more slides about future directions. The first is whether this might have applications in vaccine development. So I mentioned early on that the pre-erythrocytic stage vaccines target the liver stage, and so we've been thinking about whether this could be useful for understanding where in the liver stage vaccines were acting, and also whether they would break into the blood stage. And so these are our first set of data that we did with Scenaria. And essentially what we did was use their attenuated strains and their wild-type strains. And so what you see in this experiment is that we see equivalent amounts of infection when we use the wild-type and attenuated strains, but we see differential amounts of progression. So the attenuated strains stay small, and they only ever express these early liver stage markers, and the large strains grow bigger. The wild-type strains grow bigger, and they express late-stage markers. So this is a potentially, I think, useful way to start to look at this, some of the attenuated vaccines in culture. And finally, the Nobel Prize on Monday for Physiology and Medicine was awarded to Shinya Yamanaka for induced pluripotent stem cells. And I want to mention that we think these are potentially really attractive renewable alternative to the hepatocytes in this system that offer the potential to actually personalize these models. So for those of you who are not familiar with this, this discovery, essentially what you do is you take a skin biopsy or a blood draw from a patient, you isolate the fibroblasts, and you can reprogram these cells with 4 transcription factors to be pluripotent. Those are called induced pluripotent stem cells. And then you differentiate them in vitro along the lineage of interest. And so working with Stephen Duncan, what we've done is made hepatocyte-like cells from patients of interest. Over the last couple weeks, we've now shown that we can infect these with 3 different species, 2 rodent and 1 human, of malaria. So we can potentially establish personalized models of malaria infection. So this is my second and last plea to the crowd, and that is, again, if there are interesting clinical phenotypes that might have at their genetic basis at the liver stage, I think it could be really interesting to start to think about modeling some of those patients in a personalized fashion in some of these in vitro systems. So this is just a summary of what I've told you about our falciparum and soon-to-be Vivax, I hope, system. Overall, I think that tissue engineering has the potential to provide improved models of human disease, not just of the liver, as I hear you all talking about TB and many of the other pathogens. I think there's a potential actually to address some of those as well. The microlivers that I've shown you support the full liver stage of falciparum, and then it looks like we can establish antimalarial IC50s in this system. It supports some of the liver stage of Vivax. We haven't yet gotten the blood bursting going with the Vivax yet. We see small forms. We don't know if they're hypnozoites. We see improved antimalarial metabolism. We think there may be vaccine applications and the potential to do personalized disease model development. So I want to really thank you for your attention. I want to thank, this is my malaria team run by Sandra Marsh-Riera. They are really brave 3 bioengineers that have been doing planes, trains, and automobiles all over the country. They will come where your malaria is. Thank you for your attention. Sure.
Conscious of the time, if people do want to leave to go to poster session, nobody's going to be offended if anybody does leave, but we can take some questions now. I'd just like to ask Cliff and Wendy to come back up on stage. Okay, any questions out there? Pradeep.
Cliff, it's Pradeep here on your left. So I've really enjoyed the talk a lot, and all of them, by the way. And I wanted to find out if the final set of data you showed could be used to close the loop in terms of your screening systems. So I didn't know if that compound that you showed, linezolide or whatever it was, whether that came from some selective screen that was more informative, or whether that just happened to work well for other reasons, and whether that compound could be used to figure out what metabolic conditions would be best for doing screens for the compound.
Yeah, that's a good question. Unfortunately, at this point, we don't have any conditions in vitro under which we would have selected that compound, and we've looked hard. I mean, we've looked in every cell type we could think of. We've tried to mimic the environment, and at the moment, it still is a completely static, moderately active drug that would never have passed the first hurdle. It would never have been selected from that. So we're working hard to re-engineer that, and particularly from the patient samples, by looking at what those bacteria are experiencing over time as the patients were treated with linezolid. But at the moment, we can't close that loop. But it's a good thought.
Larry?
So I wanted to ask Sanjita about the hepatocytes. So when I think about microenvironments, and the liver included, I think about cell-cell interactions that occur within this organ. And it was striking to me that the word Kupffer cell never came up, and wondered whether it may be not scalable to work with the Kupffer cells, but with regard to cell-cell interactions and the effect on the biology of those hepatocytes, did you at some point play with the co-cellular model rather than the feeder fibroblasts?
Yeah, that's a great question. So we actually, in our Gates proposal, there is a Kupffer cell, and we do have a Kupffer cell model. It doesn't seem to improve falciparum infection, but it does improve HCV infection. We've looked at all the other non-parenchymal cell types, endothelial cells, stellate cells. There's something about this subclone that's particularly good, and we have a whole RNAi project trying to figure out what's so good about it, because it's not physiologic. So the Cooper cells are a practical problem. I think we could hammer more on it, but they need to be from the same donor. And they get activated really easily. The other thought we've had is to take a human macrophage cell line that might be a proxy for a Cooper cell.
I was just thinking in the context of 5X reactivation.
Whether it's important, yeah. But that's a good idea. That's a good suggestion. I haven't looked at it there.
Okay. Did you?
My question is also for ETA. So for your microlever. So in your microlever system, do you see the biochemical system formation?
We do see that. I was trying to describe that chicken wire network on that one slide is the biokineliculi that are forming. So the hepatocytes form tight junctions between them. And if you put in a transporter, a biliary transporter, a dye that's transported by that system, you see it light up. And then you see bile acids, for example, in the right location.
Thank you. So also I have, I think, follow-up question of previous one. So about Cooper cells. So if this microlever is for liver toxicity study, probably Cooper cell, activated Cooper cell probably is important because that's correlation with all this hepatotoxicity related.
It's very true. So the company's actually shown that LPS-activated Kupffer cells sensitized to some drug toxicity, as you would predict. Yeah.
One curiosity, you mentioned about the liver uses biotechnology. So do you know anyone or you plan to any micro lung?
A micro lung?
Yeah.
Yeah, so Don Ingber has been working at Harvard on a lung on a chip model, and they've looked at sort of nanoparticle transport, but not infection, as far as I know.
Perhaps I can ask Wendy a question then. It's very interesting looking at the point of care diagnostics. From your experience in South Africa, how easy is it going to be to replicate that in other countries?
Well, I think it's probably, are you talking about just the gene expert rollout
overall,
or the system of the multiple point of care? I actually think it may be easier to replicate in other countries than in South Africa. And the reason being is that we have a legacy of culture labs, we have a legacy of other ways, and so it may be easier to put a simpler model in another country where the infrastructure is less, actually. It's a bit like IT. If you already have 3 IT systems, to bring in something new is so I think it's probably be easier.
Right.
In South Africa, we're going to have to see how it fits into a tiered laboratory system. It doesn't make sense to just chuck out what you have. We are probably going to have to identify gaps, and the gaps will be where this would be most appropriate. If you look at the human resources required, total decentralization may just never be a reality for us, just from a pure cost perspective, because of burden of disease.
Right. Thanks. Any further questions? If not, I think I'll wrap up the session here since we're running late. And I'd just like to thank all 3 speakers again for some excellent presentations. Thank you.